Please be.
All right. Well, welcome everyone to the 2026 Scientific and Family Symposium for the Norse Institute. We're going to have this done over 2 days, today, July 14th, and Thursday, July 16th. And Krista Eschbach, Nora Wong, and myself had a great time. We're putting together this symposium. The goal of this symposium, well, this year we changed the symposium slightly in that in the past we used to have separate audiences for the Scientific and Family Symposium. But this year what we wanted to do was that we wanted to combine the two, the clinicians and the scientists and the patient family audiences, around what we consider the important points in the stages and treatment of NORSE, and have each group present their views. And we wanted to have everyone in the same room sharing their different perspectives and learning from each other, because that's what we need to do to advance our management. So basically what we are doing for today is to present the concept of the phases of NORSE, the clinical manifestations, the serum and CSF biomarkers, the various treatments, anti-seizure and immune treatments, our treatment goals, and especially talking about what the families need along the way. I already said what we were going to do on day one. On day two, we're going to focus on when do we change the approaches to treatment and what is the impact on outcome. And we believe that we can use the staging of the disease to make these changes in management and to predict what may happen in the future. Particularly on day two, we want to comment on our seizure management and how it changes from total seizure control to a seizure burden to then where we aim for a quality of life. Questions that we want to answer is, where does the acute phase end and the recovery begin? Which biomarkers carry the most weight across the phases? When should anti-seizure and immune therapy be escalated and when de-escalated? And how should we weigh the seizure burden along the long-term qualities of life? But through this, we will emphasize clinician-family communication, and this is critical in patient management. And particularly what makes it more difficult is the uncertainty that goes along with NORSE and FIRES. This is a rare disorder. There's diagnostic and prognostic uncertainty and high morbidity and mortality. It's not a diagnosis in itself. It's a clinical presentation, and it is a disorder that families have never heard of before. And so families will have no conceptual framework or terminology to understand, discuss, or plan for NORSE. And our actionable item from this conference is that we want to create a roadmap that prepares families for the long journey ahead. And we want this to be not just for the families, but for the healthcare professionals who take care of the patients, because the management goals will change over time depending on the phases. We want to define and standardize the terminology that we use for the phases, and we want to, speak the same language. And the only way that we can speak the same language is that if we have carefully defined our terminology. So I want to stop share here. Then I need to go to here. Oops. Oh, share that. And hopefully you see my slides. Okay. So what I'm going to start out doing is to discuss really the concept of the acute phase versus the chronic phase, but really try to identify how this helps in our management. I really have no disclosures. In general, we're going to talk about the concept of phases and the importance of defining these, and how does this help in the patient management. We want to define NORSE FIRES and its phases. And has there been consensus on this? Well, there hasn't. Initially, this disease had was reported as many, many different names. And the problem that this led to is that many providers or families weren't sure what to do with all these different names that were floating around. So as a project of the Norse Institute, Larry Hirsch put together a consensus on these definitions in 2018. And I believe that this has really helped to it's helped to manage the patients. It's helped to create the research that's been done that has led to a lot of the advances that we have. And what we're hoping is that by defining the phases, that we will be able to define markers, biomarkers, or even neuroimmunological markers of a given phase that can aid with our treatment strategies and when to escalate and de-escalate therapy. The problem, though, is how do we manage a rare disease? Norse fires has about a 1 in a million occurrence, so very rare. The title of our symposium last year was Early Recognition, Early Treatment, and Early Communication, and the importance of making early diagnosis. But in order to make an early diagnosis, all medical providers across all institutions need to know about Norse fires. And of course, this is very difficult to do with a rare disorder. So how do we go about doing this? Well, there's natural history studies, biomarkers, registries, multi-center collaboration, and clinical trials that can all add to this. But these all start by defining the disease and characterizing the disease. I'm not going to go over all the categories of refractory status epilepticus, but just to say that Norse fires is refractory status epilepticus. And in order to identify it early on, we have to be thinking of Norse fires every time we see a patient with refractory status epilepticus. So what is Norse fires? It's really a clinical presentation of refractory status epilepticus, not a specific diagnosis in itself. It occurs in a patient with no pre-existing epilepsy or relevant neurological disorder. And part of the definitions that were important, or the consensus that was important, was fires or febrile illness-related epilepsy syndrome occurs in all ages, but it's really a Norse subtype. So that's why you see us using the term Norse/fires together. We tend to see the fires perhaps more in the younger children, but that's not absolute. And for fires, we would have a patient with a prior febrile infection from 2 weeks to 24 hours before the onset. They don't need to have an actual fever at the onset of the refractory status. Again, the importance of studying the phases of a disorder, and I'm not going to read all of these from here because I'll mention it when we get to the Norse fires, but this is essential for us understanding, preventing, and effectively managing a disorder. The phases tell us what we can expect from a disorder, how we should treat it, especially in its various phases, which may have different treatments. And hopefully this will lead to improvements in the quality of life and prepare the patient and their family for what comes to the future. Now, I'm not going to go over this table because many of the speakers will talk about these points in their talks, but basically for the stages we have a prodrome or a prodromal stage, an acute stage, which may have a subacute stage to it. There's a latent stage, or what's called a transition stage, and then there's a recovery phase, which is also called the chronic stage. Now, there's not 100% agreement that all these stages really exist. I put these up here as an indicator that there are many stages that we're talking about, but part of what we want to get out of this in the end is to come again to a consensus of what we should be calling the stages and what are the clinical manifestations and the biomarkers of all these various stages. I'm going to particularly just mention one thing because early is important. Early stage identification is important. And EEG-wise, there are 3 patterns that we see early. The delta brush, and that we are going to have a biomarker talk, so I'm not going to go over that anymore. The low voltage amplitude seizures at the onset, and seizures that flip back and forth from one hemisphere to another. In our in our ICU EEG reading room, we have these three things up on the wall with think fires underneath it. Because if you see a patient with refractory status epilepticus and in whom you see these EEG findings early on, this should tip us off to NORSE or fires. We've done some work where we looked at what's called a highly epileptiform burst on the EEG. And this may actually be a biomarker of when we're able to de-escalate some of our therapies. It's showing us that there's less what we term malignancy in the EEG. I'm really going to not say too much about the MRI findings because Dr. Yu is going to do that. The important point is that MRI may be normal early in fire. So if you see a patient with refractory status epilepticus who has a normal MRI without other pathology, you may want to think fires. The Claustrum sign may be seen specifically for fires or very high incidence with fires, but that may not occur from maybe the first 1 to 2 weeks of the disorder. So in the end, the benefits of studying the phases of NORSE fires are that they guide the early detection and prevention. And we already have some research showing the biomarkers, inflammatory biomarkers suggesting NORSE fires. And I mentioned the EEG and the MRI. Benefits of studying, it informs our treatment, timing, and strategy. So we have the strategies of symptomatic anti-seizure treatment and targeted immune treatments. Research has shown that there may be different biomarker cytokine patterns in the acute and chronic phase, and this may help us to de-escalate treatment and determine treatment if seizures recur. We may get benefits predicting outcome and identifying risk factors. There's been some abnormalities in the neutrophil to lymphocyte ratio in the CBCs that may indicate prognosis, and knowing what to expect in these phases may help us with the quality of life, especially in how we treat the patients and what our goals are in each phase. Improving clinical trial design, the Combat NORSE trial, which is coming up. That is a study that we are going to do anakinra versus tocilizumab, immune treatments. We don't know yet whether one is better than the other. This study will help us with that. Supports public health planning and important provider education. As I mentioned earlier, we have to get the awareness of NORSE fires out there at all levels. I learned early on that the treatment of the neurocritical care patient doesn't begin at the door of the ICU, it begins in the field. And we have to make sure that people early on, the early providers in this, are aware of this disorder. And finally, we want to enhance patient and family understanding. We want to improve the communication. The more we know about NORSE fires, the more we are going to be able to decrease the uncertainty, which is a major problem in patient care and in communication. And you may say, well, what's been one of the benefits of this? And I'm going to end here with showing this is a treatment protocol that we came up with that is defining the early stages of the workup, the presentation, and the recommended treatment with the goal of identifying this disease early and treating early. Thank you very much. So next, we're going to have Dr. Andreas Van Balen from Kiel University in Germany speak on the phases. I can only say that Andreas is the one that has coined the term fires, and I think that led to a great move forward in us identifying all the patients that had had other names. So Andreas.
Okay. I hope you can see my slides.
Yes.
Yes?
Yes.
Okay.
But
yes.
There's the echo.
Dear families and colleagues, I would like to thank the organizers for inviting me to to this year NORSE Scientific Symposium. Today I would like to present the spectrum of clinical manifestations throughout the different phases of NORSE and FIRES. I will focus on both the acute and the chronic phase and present data and photos from our multi-center FIRES registry that illustrate the wide variation in the disease cause and outcome. I would like to begin with our very first patient with FIRES, whom we treated in 2006. This previously healthy children illustrate that FIRES is a multiphasic and severe disease. Let us first look at the acute phase of NORSE and FIRES. The following study shows the clinical data and investigated the acute phase treatment of FIRES, focusing on anti-seizure medications and deep sedation with therapeutic coma to examine association with long-term functional outcome. We analyzed data from 93 children, assessing acute phase anti-seizure medication and duration of therapeutic coma. Neurological outcomes were assessed using the modified ranking scale to explore association between treatment intensity, functional outcomes, and survival. This slide summarizes the patient characteristic. On the left, you can see the age distribution, the typical age distribution of the cohort, and on the right, the wide variation in the number of anti-seizure medication becomes apparent. This figure shows the distribution of the modified ranking scale scores. The outcomes range from mild disability to severe neurological impairment. Here we can see duration of therapeutic coma. Some children require no therapeutic coma, whereas others remained in therapeutic coma for several weeks. This illustrates the enormous differences in disease severity among patients with FIRES and NORSE. This study demonstrates three important findings. On the left, higher anti-seizure medication count was associated with poor outcome. In the middle, longer duration of therapeutic coma correlated with more anti-seizure medication, and on the right, higher modified ranking scores indicating inferior outcome. To conclude, increased acute treatment intensity and longer duration of therapeutic coma were associated with poor functional outcome. These observational associations are likely confounded by underlying disease severity. Having discussed the acute phase, I would now like to move to the chronic phase. There is a wide variation of clinical manifestations through the chronic phase of NORSE and FIRES, as you can see. However, most children have learning and behavioral disturbances and refractory epilepsy, and several children have language disorders like aphasia. The cognitive recovery is also highly variable, but mostly incomplete and at lower level. We analyzed 19 children from our cohort using the Glasgow Outcome Scale Extended, and we found a median score corresponding to upper severe disability with a wide range. However, better outcomes are possible despite NORSE and FIRES. The chronic causes also vary. Here we analyze 54 children. Most children showed an improvement, the green lines. Some children showed a stable disease, gray lines, but some children declined over many months. We also investigated the longitudinal MRI findings in 31 children. This retrospective study found that the MRI findings were frequently progressive, despite a stable chronic cause. However, brain atrophy was not related to poor outcome in all children, despite fires, as you can see on the left photo. The simplified summary of recovery rates in NORSE and fires demonstrates that 30% have a good recovery, 30% a moderate, 30% a poor recovery, and 10% die. Finally, healing is possible. A miracle involved the 10-year-old Candela from Argentina. She fell ill with severe acute encephalitis in July 2011 and suffered from uncontrollable, life-threatened epileptic seizures, diagnosed years later as fires. She eventually went into septic shock in a hospital in Buenos Aires. Doctors told her mother, Roxana, that death was imminent, and Father Jose Dabusti, who later wrote about the case to Pope Francis from a nearby parish, advised her to pray to John Paul I. On October 13th in 2022, and I was in Rome, Pope Francis recognized a miracle, the child healing from fires, attributed to the intercession of John Paul I, who died in 1978, with a view to beatification. Of note, he died 33 days after his election and was known as the Smiling Pope. I would like to conclude and to propose the following hypothesis: that fires and NORSE are spectrum disorders, as with other diseases, meaning that also the outcome depends as much or even more on the severity of the patient's condition as on the best currently available treatment. Therefore, despite all therapeutic efforts, outcome may be poor. My hope for the future, from NORSE to no refractory status epilepticus. Thank you very much for attention.
Thank you very much for that talk. And as I said, Andreas has been on the forefront of the definition of fires. So we're going to move on now to our family panel discussion. And what this will entail will be family members reporting their experiences with NORSE fires, and particularly perhaps discussing what their opinions are above our use of the different phases of the disease. And I can assure you that not all of the doctors that are on here today are referring to the same phase when we mention it. And I'm sure that from the family's perspective, we are not probably defining the disease and perhaps the ways that are the best for them. And part of, again, what we want to do out of this discussion is come up with ways so that we can have better provider family communication, because we think that communication is central in getting rid of uncertainty and central in preparing families for the future. So I believe Desiree is going first?
No, it's Dr. Ali.
Oh, okay.
Hello, everyone. My name is Shabana, and I'm a GP in London, and I'm Layla's mum. Today, I want to share what we see, what NORSE looks like from a family side. Layla was a completely healthy, well child at school. She was doing all the normal things a 17-year-old would do. She was looking forward to her 18th birthday, which was in 2 weeks' time. A nurse came on suddenly, no warning. One day we had a child with fever and a headache, and within days, we were in intensive care. The first things families see, how fast normal disappears. What we saw in hospital was seizures that wouldn't stop despite multiple medications. We saw coma. We saw the intense environment of intensive care. We saw doctors telling us they didn't know why. There were seizures that wouldn't stop. We heard the word NORSE fires for the first time while we were trying to process that our child might not survive. What we see as parents is medical teams working incredibly hard, but also a condition so rare that there is a no clear pathway, no leaflet, and no what happens next. Layla survived, but survival is just the start. What we see now is rehab. She had to learn to breathe again, walk again, talk again, therapies every day. We see the aftermath of the prolonged coma. She has complications, renal complications, which are ongoing. She has a lot of medication to take, tablets and suspensions of different tastes and colors. But we also see resilience. Layla working harder than any of us to get back to life, to get back to normality. But we also see gaps in care. We also see lack of training, lack of understanding. We also see appointments being cancelled, scans cancelled, heat waves without no mitigation for cooling. And the administration of all of this becomes another illness to manage. What we saw, what we see that helps was when teams talk together. We were very lucky. Layla's neurologist saw her almost every single day. And she took the bull by the horns and grabbed the bull by the horns and took the challenge of taking Layla's treatment on. And she was incredible, just absolutely incredible. But the real difference came when the intensivists, the nursing staff, everybody else that was included in Layla's care came in one room, a multidisciplinary approach. We saw Layla's care enhance when they started to communicate with each other. We didn't have to repeat Layla's story 10 times. And being believed when we say that this isn't right, or Layla is overheating, or with this medication, or there's some changes in her catheter bag. And that what really being believed also helped. And then tell us the truth. Also tell us about the research, especially symposiums like this I didn't know happened. And I came to know about that. And I came to know about other families, other patients being affected by the same illness. And that kept us going. Meeting Nora, knowing about the NORSE Institute, this all helped us keep going. And also seeing Layla, not just the NORSE. She's still Layla, she still jokes, she still has goals. And if one thing I would say to take from today, for clinicians, remember the families in the room. We are part of the care team. We lose sleep, jobs, days of our lives to keep the care going. Partner with us. For researchers, keep studying NORSE. It's so rare. I met some researchers as well, passionate. This is 100% of our lives. Updates like this at the symposium, they give us answers, they give us hope, they give clinicians guidance. And for families, know this, that you're not alone. It's the hardest thing. And there is life after intensive care. Layla is still on a journey. We don't know what the final chapter will look like, but what we see is strength, what we see is different, what collaboration makes. Thank you for listening, and thank you to everyone working so hard to understand and treat NORSE. Thank you very much.
Thank you. Thank you very much for telling that. I'm sure it's very difficult to deal with. We hope that an organization like the NORSE Institute and the work that we're doing here will help people now and in the future to get over this, or to get through this in a better way. So thank you very much for bringing your thoughts forward. Yes, Desiree?
Hi, I raised my hand because I'm next for.
Yeah.
Thank you so much, Siobhan. That was great. Thank you. So my name is Desiree. My son is David, and he was diagnosed 9.5 years ago. He's now 16 years old. One thing I would encourage clinicians to emphasize is the value of parent observations, especially in the chronic phase, because every NORSE and FIRES patient is different. As families, we spend years living with our loved ones and often become very familiar with their baseline, their seizure patterns, and subtle changes that may not be obvious during clinic visits. Clinicians may see a patient for hours, days, or a few visits per year, but families see them every single day. We witness the fluctuations, the recovery, the setbacks, and the things that happen between appointments. In our son's case, we've observed recurring behavior patterns before seizures, cold and clammy feet before experiencing postictal psychosis. Families may not always know the mechanism behind a change, but they often recognize the pattern. I'd also encourage clinicians not to dismiss subjective observations simply because they're difficult to measure. Many of the most useful observations we've made over the years have been subjective. Recognizing a behavioral and cognitive shift after an anticonvulsant increase ultimately led to the discovery of ammonia toxicity and saved my son's life. Families aren't just caregivers, they're often the longest running observers of these syndromes. Treat family observations as data. Even when the data cannot yet be explained, it may help identify patterns, improve care, and generate new questions for research. One final point I'd like clinicians to consider is that diagnoses affect more than the treatment. In our experience, obtaining an autism diagnosis was essential for accessing ABA therapy. David is now 9.5 years post-onset and only began ABA therapy 2 months ago after years of advocating for that diagnosis alone. Families aren't only navigating NORSE and FIRES, we're navigating systems of care, and the diagnoses and documentation you provide often determine whether therapies are available at all. Thank you.
Thank you very much also for your observations. I think that one very, very important point there for not just the NORSE FIRES group, but for any patient, really any patient, but having dealt with chronic epilepsy, the families are our eyes. The families see the patients. They report to us what the patient is doing, and it's up to us to listen to what they say and to use their observations to help us best manage the patients. And I think that that is something that we need to emphasize and is quite important, especially as she mentioned something like a drug toxicity. It might be some small change or subtle change in the patient's behavior that would lead to that. So very important. And as you also mentioned, the navigating of the systems. The medical system is not easy to navigate. And families are the ones in the end that are left navigating that system. So in part, we really want to put together something that at the beginning we could have as well, as I said, like a roadmap where we bring that up to people's attention early on rather than have them find that out later in the course of the disease. So I think that that's very important. Thank you very much. Now is Massimiliano next? Okay.
Hi, everybody. My name is Massimiliano Cignatta from Italy. I'm father of a 10-year-old boy who was affected by fires with onset on April 2020. So we were in the full COVID period. So it's almost 6 years since he's in the chronic phase. Before the onset of the fires, he was fully healthy without any problem. According to the presentations that I have seen, I would emphasize that in our case, after the acute phase, we went through what I call the silent period. It has been named the transient phase in the presentation. So in our case, the seizures stopped during his stay in the ICU, and he was seizure-free for around 4.5 months. Okay, so during this period, EEG's report, which were performed partially during the rehabilitation center and partially after the discharge, mention a disorganized background activity with slow non-epileptiform waves primarily localized in the right temporal and central region, especially during the sleep. Okay, so we got this silent period. Now we are in the chronic phase, so as per the others, we are facing drug-resistant epilepsy with multiple focal seizures per week. And in our case, most of the time, they are triggered by variation of the microclimate. So if my son passed from an environment to another where temperature or humidity are different, and sometimes by emotions, even small emotion may trigger his seizures. His seizures are basically focal seizures. So what we observe are behavioral arrests, so freezing basically, mount and sometimes eyes and head deviations, and chalorrhea. This is what we see in his case. In terms of other aspects, we are facing learning difficulties and also behavioral disturbances, in particular oppositional and defiant behavior. On this last point, it is not really clear if this is due, I'm talking about the behavioral disorder, if this is due to the anti-seizure medications or to the disease itself. So it's something that is not really clear to us yet. Thank you.
Thank you very much. I might just comment on your mentioning the silent period or the transition period, because part of what we want to do today is also for the families explain to you why we think it's important to define the phases and what's going on with the biomarkers and other medical tests that we can do during those phases. So especially when we have a transition phase, in my mind, that would be the phase where maybe the acute neurological insult is over. Perhaps that means that if we're dealing with an immunological disorder of innate immunity, which is what we think, that has quieted down. And particularly then when seizures come back, we don't know whether the seizures are coming back secondary to like a new onset epilepsy following a brain disorder, or whether the person still has some immunity abnormalities, which we would treat totally differently than we would treat, say, epileptic seizures. So I just want to emphasize to everybody the importance of the work that's being done to try to identify what we call the pathophysiology of what is going on in each of these phases, because we do believe that it will change, or it can potentially change our treatments depending on what are the underlying pathophysiology. So I think that that's an important point. The other point that I think is important for families is when Massimiliano mentions the microclimate variations. And that is something that we read about all the time with epileptic seizures. I've seen patients where high temperatures or low temperatures or temperatures outside of a certain range will set off their seizures. So important for people to for the families to bring that up to us when you're seeing, when the patients are being seen back. Emotions, we don't typically think as an epileptologist that emotions would start seizures. But if somebody with epilepsy or with seizures has a change in their emotions, that could change their neurochemical balance in their brain, which of course could lead to seizures. So important for us to know, listen to, and to take that into account. There's studies of barometric pressure. The changes in the barometric pressure might bring out seizures in a given person. We talk a lot about the phases of the moon. There's some studies where people have looked at whether that really is something that happens. So I think it's important to bring forward what you recognize in the patients to us, because they can all be very important things for us to listen to and determine whether there's any specific treatment that we should do. So thank you very much for bringing that forward, and particularly for making that point. I believe that Carla is next.
Yeah, hi.
Thank you.
Sorry. Hi. Sorry, I'm nervous. But my name's Carly Yankowski.
I am too, so feel at home.
Okay. Well, my sister Alexandra was a NORSE patient from 2019 to 2022. Her case was considered a success. She was back at work and living with her boyfriend, but there's much more physicians need to consider. In my sister's case, she was back at work, but it's because they held her job for her. After being laid off due to a corporate merger, it was impossible for her to find work. She could only work so many hours per week in order to receive disability, and she felt that people she spoke to regarding employment could tell that there was something wrong with her. However, her job was really hard to do, she said, as was going back to school, filling out documents like the NORSE Family Registry, or even making decisions. She had false memories that held fast, reasoning that didn't quite make sense, messy short-term memory, misinterpretation and misremembering of events, sleeping and then waking up forgetting what day it was or who was in the house. But we were tired and we thought she was taking care of herself. I'm here to say that given my experience, we must never let our guard down on NORSE. My sister attended her doctor's appointments with Dr. Hirsch alone. She had a change in medication almost 3 years after onset, started having seizures again, then one day took all of her pills out of the blue, killing herself. She was 29. Since a change in medication in a NORSE patient can cause things to go haywire, and given her damaged mental state, we need to ask ourselves, should NORSE patients be attending appointments or undergoing changes in medication alone? How can we be sure someone with brain damage understands the risks involved, or isn't just too scared to go against what their doctor says? How do we know they will remember to report important details about how they are doing? We need to pay attention to the memory discrepancies, a story told that seems a little off, changes in behavior, however small. a bit of logic that doesn't quite make sense, an offhand joke about, what do you think would happen if I took all my pills? We saw all this and yet still thought she was handling her life just fine. And now she's gone and we won't know why ever. Was it purposeful, a mistake, confusion, deep depression, or did a seizure make her do it? Looking back, I think someone should have been attending her doctor's appointments with her, and I hope everyone considers that from here on out. Doctors, I implore, question a NORSE patient's comprehension and state of emotional well-being at all times, and open as many avenues of communication about the patient's care as soon as possible. From personal experience, I know the parents may not be the best choice for caregiver or the best avenue for communication, and other family and friends can give you a clearer picture of the patient's mental state. Do you really know what their quality of life is? Before changing medication, we should consider quality of life over seizure count. Thank you.
Yes, thank you, Carla. And especially thank you for, bringing forward your story. I'm sorry for your loss. I'm sure it makes it harder for you to tell us, what happened, but I think you made some very, very important points there, right? I mean, maybe not so much on the pediatric side, because we always see our patients back with usually several family members. But yes, what do we do on the adult side for people that are, still functional, but yet may not, well, functional physically perhaps, but may not be able to, cognitively deal with everything, especially with what we know are the cognitive problems that are associated with this disorder. And in part, that's why there's several studies going on. You mentioned the biorepository, so or the registry, so very important for us to get that kind of data, because that's the kind of data that we need in order to do the research, which will lead to improvements in patients' care. And I think particularly with the quality of life. I mean, I think that that's one of the aspects of epilepsy in all ages, pediatric and adult, that we've, hopefully been better at focusing on. Because in the past, we, as the epileptologists, used to think, well, we have to control the seizures. Controlling seizures is the most important thing that we need to do. But on the other hand, we don't want to control seizures at a detriment to the patient's quality of life. And that can be important in the acute phase as well, when we're de-escalating therapy, which we'll talk about a little bit more tomorrow. But when we de-escalate therapy and patients continue to have seizures, we have to be realistic in what we expect. And what we expect, it's important to do to do the phases and know what to expect in different phases. So if we think that someone is going to have ongoing seizures, then we're going to, in a sense, permit them to have seizures rather than just keep giving them boluses and boluses and boluses of seizure medications to treat that. So I see that Nora has raised her hand.
Thanks, Jim. Thank you so much, Carla. This was a difficult story to tell, but it's very important that you shared it, because I think it points out reflects back on even the measures that researchers use for their studies. Many of them, and we still include them, the modified Rankin scale, and it's more about basic functioning, and lots of it is more tending towards physical disability. And so it doesn't capture the psychological changes and memory issues. So Alex, Carla's sister, was seen as she said, a successful case. She went back to work for a while. She could do many things. She was physically capable. And so I think that what researchers use to measure outcome, what are the things that are important for everyday life, for a satisfying, productive, happy life, that they might not be captured in the measures that are currently being used by researchers. And that's part of what Krista Eschbach is doing with the long-term outcomes group and with the PCORI Patient and Family Advisory Board to find out, well, what are these things that patients live with, that families see, that need to be measured and addressed in patients who survive with NORSE. Thanks.
Yes, thank you, Nora. Very, very important points. And I think it shows in a sense, perhaps the shift that we've had from our treatments, right? Where initially we were probably focused very much on the acute phase, stopping the seizures, and not thinking so much about what was the long-term outcomes and the quality of life. And that's the importance of, I think, having this type of research done, and for us developing a roadmap where both providers and families can know what to expect down the road, but also because in some ways, the better educated the family, you can direct your doctor in certain ways, because many, many times we need direction. We need direction in how to care for our patients. And we've always looked upon this as, we take care of patients with, sort of mutual decision-making rather than just me telling you to take this. So I think that that's really the most important thing for taking care of our patients. So thank you. So at this point, we're going to transition to the biomarkers. We're going to discuss some of the important biomarkers in NORSE fires and perhaps link them to some of the phases. And then in the end, we'll have Desiree comment on why this is done. Thank you very much. First, we will have Dr. Aurélie Hanin from the Sorbonne in Paris talk about the biomarkers. Thank you.
Thank you, Jim. So good morning, good afternoon, everyone. First of all, I would like to thank Nora, Krista, and Jim for inviting me to discuss today about the biological biomarker of NORSE. And I will try to give you an overview of what has been done in both acute and chronic phases. So in the past few years, extensive research has been published on NORSE, but most studies focus on acute biomarkers, meaning biospecimens that have been measured and collected during the acute phase of NORSE, so during the hospitalization for status epilepticus. And if we want to summarize the research that has been conducted, we can group the biomarker in 4 categories. Inflammation biomarkers, this is the most extensively studied, with notably the cytokine measured in both blood and CSF. The second category is genetic, and I'm sure that Daniele De Campo will discuss more about that later today. The third category is a brain injury biomarker, aiming to reflect what are the consequences of the seizure on the brain. And the last category takes advantage of the new technologies and aims not to investigate a specific biomarker, but to look at all the protein with proteomic approaches, or all the RNA with transcriptomic approaches. And we now know that it's important to combine these different aspects. So today I will focus on the 3 categories: inflammation, brain injury, and proteomic transcriptomic, and trying to show you some examples of studies that have been conducted and link both acute and chronic phases. So the first study I would like to point out is a study conducted by Stefano Meleti in Italy and recently published. In this study, Stefano and his colleague measured the neurofilament light chain. This is a biomarker that can be measured both in the CSF and in the blood, and that is reflecting the neuroaxonal injury. In this study, they compared the cryptogenic NORSE cases to patients with a status epilepticus and an etiology identified. And they tried to assess the correspondence between higher NFL levels and the functional outcome. As you can see on this graph on the left, patients with cryptogenic NORSE had higher serum NFL levels compared to the other groups. And if we have a zoom to this population, we can see that the patient reached a peak around 10 days after seizure onset, making important the dynamic of biomarker evolution. Additionally, in this study, they found that the patient who had the most important elevation of NFL had a poor functional outcome at discharge and a higher risk of dying in the ICU. These different results make NFL as a promising biomarker to reflect the acute brain injury and potentially to predict NORSE outcome. And importantly, in another cohort, we confirmed these findings, but also highlighted that NFL levels in the acute phase also correlate to what happened 12 months later during the chronic phase as a functional outcome. The second study I would like to point it out investigate a more commonly measured biomarker that is a complete blood count. This is a test that is daily performed in all ICU in the world. And the objective of the study was to look at the CBC features and try to see if they can predict the 12-month functional outcome in fire cases. So in this study, more than 1,500 CBC data were collected, 2/3 for adults, 1/3 for children. Patients were divided in good or poor outcome, and each CBC data was classified in a treatment period, no immunotherapy, during or after first line, and during or after second line. We obtained a decision tree for each group, age, and treatment period. A decision tree is something looking like this, where you can follow your patient according to the CBC data. And at the end, you have a category, favorable or unfavorable outcome. With this model, we were able to accurately predict the outcome in 87% of the children and 83% of the adults, making CBC a rapid bedside tool for long-term functional outcome. The third study did not investigate a specific biomarker, but they used a new technology called O-link to investigate different types of proteins. They compared cryptogenic NORSE cases to 21 control patients. In this study, the most promising biomarker was a total tau protein that correlates both with the functional outcome and with the hippocampal atrophy. They observed that patients with higher CSF tau levels more frequently had an inflammatory profile and a more severe disease course. When we look on the MRI, this patient more frequently had hippocampal abnormality. This is represented by the yellow arrow, and a higher seizure burden represented by a reddish color when compared to the low tau levels patients. Therefore, total tau protein can also be useful to predict the development of hippocampal atrophy. The last study I would like to briefly mention today more focus on the chronic phases. So what happened after NORSE resolution? We know that we know that 75% of patients develop post-NORSE epilepsy. And what we found in the chronic phase is that we have a normalization of most of the innate immune disturbances, but that 20% of the patients develop new adaptive immune disturbances. Some modification correlate with the delay of collection after status resolution. And we also observe higher NFL level in the chronic phase, showing chronic brain injury. As a conclusion, during the acute phase, measuring biomarker can give us some information about why status is occurring, can help guide some treatment decision, predict consequences. Some markers seem to be more promising than others, including cytokine and NFL. And they can also be useful in the chronic phase to guide treatment decision or reflect ongoing neuroaxonal injury. This biomarker can also be enriched with new technologies and combined to EEG, MRI feature, and this is why we are trying to develop NORSE biomarker working group. For the general audience, as you can see, blood biomarker, CSF biomarker can tell us many things about what is happening and what we could expect. And so we can encourage you to participate in the different biorepository by sharing both acute and chronic samples. Thank you for your attention.
Thank you very much. I think that study, or Dr. Hanin's talk, tells us something very important in that we can perhaps use some of these biomarkers, not just for diagnosis in the acute phase, but perhaps also to answer questions about what will happen in the future. I see a question from a hand raised from, I think, Dr. Wickstrom.
I think he was just clapping.
Yeah, I was trying to clap. Sorry.
Oh, okay. Any questions about the use of the biomarkers or any of the ones that were discussed? I think what is interesting about the neurofilament light change is that, of course, and many of these biomarkers may not be specific to NORSE fires. They may have applications across the neurological disease spectrum, but of course they can be used in different diseases to define the amount of ongoing brain injury that has occurred. If we look at a lot of the research that is being done, a lot of it has to do with the use of biomarkers. And, we're learning a lot from these various biomarkers for how to care for our patients. I think I could perhaps ask orally a question. I had mentioned the use of the biomarkers to differentiate perhaps the transition period from the chronic period and the importance of knowing whether there is still an active immune process or if we're more into the phase of a chronic epilepsy.
Yeah, that's interesting because initially we thought that some seizure recurrence may still be due to innate immune disturbances, but our result did not find these findings. So we see a normalization of the innate immune markers. But some patients develop new abnormalities of the adaptive immunity. So perhaps we do see a conversion of one type of immunity to a second one that may suggest the use of other immunotherapies in chronic patients. And this is not seen in patients with other chronic epilepsy.
Excuse me.
All right. I'm sorry. Thank you.
There is a question for Aurelie
Oh.
in the chat. What was the biomarker measured in the CBC?
It's a panel of more than 10 biomarkers reflecting the blood cell composition, so red blood cells and white blood cells, and also the number of cells and their distribution.
I think they might be asking which one was correlated that was looked at for that study.
Oh, many of them, all of them actually, and according to the treatment period and the patient age, the biomarker were selected to have the better performance, and so the biomarker change for the different patients.
All right, thank you very much. I think we will move on to Dr. Yu speaking about the EEG and MRI biomarkers.
Thank you so much for having me. Can you see my slides okay?
You're in the not the presentation mode. We can
okay.
Yeah.
Give me 1 second.
Okay, thank you. That looks good.
Thank you. Thank you so much for having me. And I really appreciate this opportunity to talk about MRI and EEG biomarkers. And also, I really appreciate hearing from the family members. We really just learn so much from the patients and family members and caregivers. And that really, I think, help us to move this research forward. For NORSE, the consensus recommendation is to do an MRI within 48 hours of presentation. And as the definition of NORSE suggests, there's no structural etiology that we can find from the MRI pictures, especially early in the course. So when you do an MRI early in the course, it's very often normal. Sometimes we will find flare hyperintensity, which means it shows a bright signal on the MRI, and it can be seen in multiple regions, including hippocampus, insula, claustrum, basal ganglia, thalamus, and sometimes it involves diffuse areas in the cortices. And the MRI evolves over days. So what happens with status epilepticus is that there is increased energy demand because of ongoing seizures. And as the energy demand increases as the time and severity goes up, initially there is some mechanisms, compensatory mechanisms to supply that energy demand. But as it goes on, there is a gap, there's a supply and demand mismatch happening, and the perfusion is not enough to supply that energy demand, and that can cause irreversible changes. So in this picture, you can see this hyperintensity happening after status, but later it can go into diffuse cortical atrophy, including bilateral hippocampal sclerosis. And that happens in prolonged status epilepticus. And as you know, in a lot of NORSE patients, they go into what we call as super refractory status epilepticus, which means they are continuing to have seizures despite being on anesthesia medications. So this can happen in NORSE. The colostrum sign has been described, and this is usually seen in average about 10 days, and it can resolve over the following weeks. And the colostrum is an area where it's closely connected with multiple different areas, especially in the frontal and temporal regions. So when you see this, it's not specific, but it can be highly suggestive of ongoing status epilepticus and NORSE. So as I said, MRI evolves over time. Often on day one, it is often normal. And around week 1, you can see colostrum sign, limbic changes. As you go into weeks, you can see different cortices swelling. And in month period, where we would call it as a chronic phase, you may see this diffuse cortical atrophy and hippocampal sclerosis. So it's seen as an example here, in this 7-year-old who had fires. In the onset, you can see pretty normal looking MRI. On 10th day, you can see a hyper intensity signal, bright signal over here. And you can see these bright signals involving multiple other regions of the brain. And when the MRI was repeated in 6-month period, you can notice how the volume of the brain has shrunken and showing atrophy, and including sometimes hyper intensity in the hippocampus, showing hippocampal sclerosis. So let me move on to EEG biomarkers in NORSE. So continuous EEG is recommended for essentially all NORSE patients to diagnose and manage ongoing seizures. And why EEG is the best real-time biomarker is because it's dynamic, it's continuous. Unlike MRI, we cannot do MRI continuously. And we can use the EEG to monitor the treatment. It helps us to calculate the seizure burden. So it is the best real-time biomarker. There are some EEG biomarkers that we can think of inflammation. Seizures often migrate from one place to another. It involves multiple brain regions. Unlike some other, epilepsy patients, we often see one area of the seizures coming on, but in NORSE, we often see these seizures from one place to another or multiple places at once. It's showing the network instability, and EEG reflects this inflammatory network dysfunction. Dr. Riviello mentioned about delta brush and some low voltage fast onset. Which delta brush, if it's a marker for specifically NMDA encephalitis, and sometimes these EEG findings can help us to see we are dealing with some diffuse process or neocortical process. So those markers can help us to also guide us. There are some potential markers for prognosis, including prolonged non-convulsive status, seizure burden, anesthesia dependence, and persistent periodic discharges, and when to expect the return of background. These can help us to prognosis. So we have done multi-center study, which was recently published in Epilepsia. Dr. Gilani, who is an assistant professor at Mount Sinai, was the first author on this study. So we have compiled 44 patients from the Yale Biorepository and looked at their continuous EEG findings. They were average 29 years old. Most of them were cryptogenic. A lot of them had fevers. About 60% 20% had seizures after discharge. And for these people who had seizures after discharge, they were getting an average of 4 medications versus who didn't have seizures. They were able to de-escalate a lot of seizure medications, and average they were getting 1 medication. And at the onset of status epilepticus, most of them were convulsive or focal motor status epilepticus, like twitching on one side of the body. Seizure location was median of 2, usually involving multiple areas, as I talked about. And status epilepticus captured on video EEG after clinical seizures were controlled. Most of them were non-convulsive, but if there were manifestation, if it was often epilepsia partialis continua. And seizure burden was about 15% in the EEG monitoring. And when we compared the patients who had seizures after discharge versus didn't have seizures, the patients who had seizures after discharge had more seizure burden and more video EEG days which had seizures, and seizure type was more likely to be electroclinical. In the chronic phase, when we looked at these patients, average of 20 months later after discharge, a lot of them had return of posterior dominant rhythm, which means their function has recovered a lot. But there were many times, many of the patients still had epileptic form discharges and periodic discharges, and 1 out of 4 patients had captured seizures on EEG, and the EEG seizure onset were variable. I do think this needs to be better studied chronically to see how these features, this includes a small number relatively right now, but I think this can be better studied. In these patients who are still getting seizures, we often explore other than medication options such as epilepsy surgeries and neuromodulation therapies. Thank you so much.
No, thank you very much. At the onset, I forgot to say that Dr. Yu is from the Mount Sinai School of Medicine in the great city of New York. There is a question from the chat room about a recommendation for repeating an EEG in the chronic phase and how we would rule out absence seizures.
So we often, when I see these patients in clinic, I often do an EEG to see how the epileptic form discharges are occurring and where in place. And I think the observation from the caregivers are especially important for absence, or what we call the focal impaired awareness seizures or focal impaired consciousness seizures, because patients are not aware of them happening, and caregivers' observations are really helpful. So when I hear those stories from caregivers, I do have patients admit to the epilepsy monitoring unit often, or ambulatory EEGs to look for those seizures.
All right, thank you very much. We're going to move on to the next talk on a biomarker, and that's going to be Dr. Danielle DeCampo from the University of Pennsylvania.
Hi, how are you? All right, let me go ahead and share my screen. All right, are you able to see my screen?
Not yet. Yes, there we go.
Okay, all right,
But
great.
it's not in the presentation mode.
How about now?
Thanks.
Okay, great. So I would like to talk with you guys a little bit about genetic testing. I know we don't have very much time, so I'll go through what I have. Today I'd like to talk about a little bit of what we're doing with genetic and testing and why we do it. So the first question is, why should we perform genetic testing? And, I think when it comes to genetic testing, we should be performing it at the onset of NORSE and FIRES, so early. And the type of testing to consider would be whole exome sequencing or whole genome sequencing. The reasons that we would think about doing testing is because although it's rare, there are times where we find an underlying genetic cause for NORSE or FIRES. And this can really ultimately impact kind of how we think about the disease, how we think about prognosis, and kind of the roadmap for families to follow. In some cases, if we do find a genetic cause, this can influence our treatment, both in the short and long term. and then again, ultimately guide us in terms of how we think about the long-term trajectory of our families and their patients. When we think about genetic testing, I would say that the two most comprehensive tests that we can consider doing would be whole exome sequencing or whole genome sequencing. When we think about these two types of tests, I would say for the most part, either one would be useful. When we think about whole exome, this has been what's around clinically for much longer than whole genome sequencing. This typically is looking at the coding sequence of all of the genes, whereas whole genome sequencing is looking at those coding regions plus the introns, which are non-coding parts of DNA. What that means in terms of how we look at outcomes is that the majority of known genetic causes of disease are identified on whole exome sequencing. Whole genome sequencing may give us a 5 to 10% more diagnostic yield than whole exome. And at this point, I would say many times whole exome sequencing is easier to get covered than whole genome, although that is changing very, very quickly. And so I think if you can get the whole genome, that would be great. But I also think whole exome sequencing is a very good first step in terms of getting genetic testing. One thing that is important to keep in mind, and this obviously applies, thanks, much more to our patients, is that it's helpful to get this in parental samples instead of just doing it as a single person. And the reason that this is important is because this can help us in identifying different types of, help us identify some of the gene findings that are a little harder to interpret. So when we look at a genetic report, there are 3 types of results that we can get: positive, negative. A positive meaning that we find an answer, negative that nothing comes back, and then something that's called a variant of unknown significance. When we think about variant of unknown significance, I think this is really where the bulk of interpretation of genetic testing comes into play, and where it's very important to have a genetic team that's doing the interpretation of your genetic testing. Variants of unknown significance are gene findings that have neither been given a designation of pathogenic or disease-causing or benign, meaning that they're somewhere in between. They are very common. I'd expect tell families to find 1 to 3 on any genetic report. But many times they are not the answer, even though there can be a lot of overlap in terms of what we find. So I do recommend that this is always done in conjunction with a genetics team that does a lot of different analytical steps after getting the genetic report done. If your genetic test comes back as negative or has an VUS that we haven't really been able to say one way or the other, we always recommend doing a reanalysis in 1 to 2 years. And that's because we know that the DNA of the individual doesn't change, but the number of genes and gene findings that could be related to certain causes or conditions or etiologies can. So what do we know currently about genetics in FIRES and NORSE? We know that it's uncommon to find a genetic etiology. Most of what we found has to do with epilepsy-related genes, but when we think about epilepsy as a whole, we say that the yield of identifying a gene in FIRES and NORSE is lower. These are a list of some of the genes. We also, because of the immune-related background in terms of what we're thinking about NORSE or FIRES, have started to look into doing immune-related causes. I would say that that's still an area of active investigation. There have been a few genes that have been identified as potential causes, but this is still definitely an area that we're looking into. And then lastly, because we know that genetics work in kind of a background of multiple interactions, we have been starting to look at not just single gene changes and how that can be related to NORSE or FIRES, but also polygenic risks, so how multiple genes interact or cause a susceptibility background. And this has been an area that we are still undergoing a lot of active investigation. We have found that there tends to be, at least in one paper, a background of kind of autoimmune susceptibility in individuals with NORSE or FIRES. When we look at genes that are involved in kind of susceptibility to epilepsy, however, we haven't found quite the same thing. So it does tell us really about this kind of background of altered immune dysfunction could potentially put somebody at a higher risk, but something that's still going under research. So in terms of our take home,
sorry.
that's okay. In terms of our take home, important thing is to remember to do genetic testing early. If you can have access to parental samples, that can help us, particularly in terms of interpreting things like VUSs. Interpreting VUSs is important to do and important to have in the context of a genetics team. And then if you are still not finding anything, we do recommend continuing to look at that genetic workup every 2 years or so, because we do know that every year we're finding more and more new gene changes. And that is my talk.
Thank you very much. We'll hear now from Desiree regarding the family perspective on the biomarkers.
Thanks. Again, I'm Desiree, David's mom. He's 9.5 years post-onset and is 16 years old. Several years ago, I attended one of these conferences and heard several speakers repeatedly emphasize the message, send the NORSE Institute your child's brain when he or she dies. I was confused and offended. My child was living and I was doing everything in my power to keep him alive. Being asked for my child's brain after he passed when I was still fighting to keep him alive made me feel like the NORSE Institute only found value in him after he passed. All of my efforts to keep my child alive felt completely overlooked, dismissed. More emails followed asking for biosamples, with the caveat that the research was unlikely to change the medical condition of current survivors in the chronic phase. To me, asking for my son's biosamples without offering hope for his future wasn't a fair trade. That's when I emailed Dr. Nora Wong, the executive director of the NORSE Institute. After receiving my email, Dr. Nora Wong asked if I was open to meeting with her. We met, and she took the time to explain the history of NORSE, how the term evolved, and how much effort it had taken to get the medical community aligned. She explained that biospecimen research was not yet likely to help those already living in the chronic phase, simply because they were only beginning to be studied. That conversation changed something for me. It gave me context. It helped me understand that the science was still catching up to the questions families had been asking for years. Questions like, why did this happen? Why do some patients recover differently than others? Why do some respond well to certain treatments while others do not? Why do some develop cognitive difficulties, psychiatric symptoms, or persistent epilepsy while others don't? That was in 2024. What excites me now is that we are in a very different place. And the key to answering many of those questions is in biospecimens. Biospecimens are blood, spinal fluid, tissue, stool, and other biological samples that allow scientists to move beyond observation and begin identifying patterns, biomarkers, and pathways. These are the tools that can one day lead to earlier diagnosis, more targeted treatments, better prediction of outcomes, and improved long-term care. For many years, many of us understandably wondered how these samples could help our children, especially those living in the chronic phase. But now we're beginning to see real reasons for hope. Researchers are identifying patterns in these biospecimens that may help us better understand the chronic phase, explain differences in outcomes and complications, guide future treatment decisions, and perhaps even improve our ability to predict what comes next. Every additional data point helps researchers better understand the full spectrum of NORSE fires, not only in the acute phase, but in the months and years that follow. And importantly, your loved one doesn't have to pass away to contribute to that understanding. We're living in a time when biosamples from your loved one's labs have the potential to change the future for those being diagnosed today and for those who will be diagnosed tomorrow. But to me, this is about more than science. Why contribute? I'll tell you why it's important to me. Every unanswered question carries a face, a name, a future. It's important to me because I have hope that another family will someday receive the answers we never had. Every biospecimen collected is more than just another sample. It represents a story, a family, and an opportunity to transform lived experience into scientific understanding, to give another family the opportunity that NORSE and fires took from my son. One day we will know which treatments work best for which patients, and families like mine will spend less time living in uncertainty. That is the future I hope biospecimen research can help create. Thank you.
Thank you very much. You said that a lot better than I think any one of us could say. So I want to thank you very much for, for your thoughts and for being part of our panel. So we're going to take a very short break here. I'm going to say 5 minutes, but we're going to try to start again at 12:30. I'm sorry. Yes, 12:30 to hear about some of the anti-seizure and immune therapies. And again, thank you very much, Desiree.